Again, my name is Niani Dunair, and I'm the Legacy Cancer Healing Center Coordinator. And we are joined by Dr. Sage Bolte, who is currently the president of the Innova Health Foundation in Falls Church, Virginia, and previously served as the executive director of Life with Cancer and Patient Experience for the Innova Shar Cancer Institute. She is known nationally for her work in sexual health and cancer and is a respected leader in the field of oncology social work. Her PhD dissertation explored the impact of cancer and its treatment on the sexual self of young adult cancer survivors. We are very pleased to have her here with us this evening and to share her wisdom and her research with us. So without further ado, I'll hand it over to you.
Thank you so much. It's such a privilege to be here tonight. And I apologize for my lighting. I'm actually in a hotel room. I had a board retreat at the same time. So I will be a little darker in the background, but it's so great to be with you all. Thank you so much. And I look forward to sharing this time with you and talking about sexual health and intimacy during and after cancer. I'm going to get my slides down. There we go. So when we start talking about sexual health, I think one of the really important things to acknowledge is that it's okay to not be okay. You know, I hear a lot in my work with women, especially, this feeling or internal pressure to, be the best survivor, be the champion. And I want to just give permission and name that life is going to be different, and it is different after cancer. It doesn't mean it can't be better. And it doesn't mean that things may not change. Things will change, but it's also okay to not be okay with that. That we can say things might be better, but it still is not fair that cancer came into our worlds. And so, as we think about some of the impact that cancer and its treatments have on our lives, oftentimes, again, I think as women, we're focused on like getting the end, making sure our family's okay, getting to that next thing, making sure we're at work or there for our kids or grandkids or whatever it might be. We don't always give space to just acknowledge the losses. And it doesn't mean suffering in the losses or moping in the losses or bathing in sorrow, but we do need to give time to grieve what was taken from you and what has changed. We also need to give time to redefine that. So your sexual body after cancer will look different. And there's a lot of ways to redefine how you might want it to look or what you might want to learn about and redefine your own expectations, and acceptance will come. And I really like to differentiate between I accept that these things have changed. I have accepted that cancer has brought these really great or really hard things into my life. And I can still not be okay with that. I didn't want cancer. I didn't ask for it. I didn't invite it. It came, so I can accept that, but I don't have to be okay with it. And as women especially, really leaning into that and acknowledging I need time to grieve, I need time to redefine, and acceptance will come. So tonight, we're going to spend some time looking at how I might define the sexual self. It's a conceptual model as I think about who we are as individuals and our sexual bodies. Hopefully, you'll feel that some of the changes are normalized and maybe talk about some of the expectations you might have to identify the impact that cancer and its treatments have on sexual function, body image, and intimacy, and then explore ways to improve each of these really important aspects of your sexual self. And again, you can use the chat to put in questions as they come up. You can write them down, whatever works for you. My hope is this is a time where we can share and experience and ask questions around a topic that often isn't talked about. So kudos to Legacy Health for bringing this forward as a conversation that's valued by them, and it clearly identifies that they value this aspect of their patients' life. So when I talk about sexual self, one of the things that is important to highlight is there's this word sexuality, there's this word sexual intimacy, and both are valid words. But when I was thinking about my research and how do we really conceptualize so much more than just intercourse or orgasm or intimacy, but really how do we incorporate the whole body, the whole person, the whole self into the sexual experiences. And so thinking back, I'm a cognitive behavioral theorist by training. So the way we think about ourselves impacts the way we feel about things, which impacts our behaviors, right? So our thoughts impact our feelings, which impact our behaviors. I didn't think it was a far stretch to think that how we come to cancer, our previous experiences, maybe we've had sexual trauma in our past, maybe we've had really awesome experiences that inform a very confident sexual body. Maybe we've had insecurities prior. All of those things inform how we process the way that cancer changes our body. And that and those thoughts then influence the way we feel our sexual esteem, the things that we attach, like I feel broken, or I'm damaged, or I'm never going to be the same. And that's those thoughts that we identify. And then that affects the feeling. So if I feel like cancer's changed me and no one will ever find me attractive, most likely that feeling is going to be depression or anxiety. And that behavior then is going to be withdrawal, or not putting myself out there, or potentially even that dating people that I might not prior to cancer have dated because I don't feel I'm worthy. Where if I come in and I think my sexual esteem is, yes, cancer has changed my body, and I am very capable of adapting to the changes it has. It may be different, it may look different, it may feel different, but I'm confident I can adapt. The feelings I'm going to have are going to be those of confidence. There may still be some insecurities, but the confidence or confidence in my ability to manage is going to affect my behaviors, which might be, if I'm single, I might be willing to put myself out there a little bit more. I might be willing to have conversations up front around some of the changes. So my nipples aren't sensitive anymore, but these parts of my body still are. All of that, again, is our sexual self. The way we think about, feel, and behave is all part of our sexual self. And the impact of cancer on sexual function is profound. Nearly 100%, and I would probably venture to say 100% of women diagnosed with cancer will experience some change in their sexual self. And that might be, you notice that you had increased anxiety or depression and we prescribed an SSRI to manage that. Well, that has a direct effect on sexual function. You might notice that areas that were sensitive before are no longer sensitive. And so you're having to recreate and redirect areas that maybe weren't sensual before, but now are becoming sensual parts of your body. That can have an impact. But the greatest complaints and challenges that women report out consistently, regardless of the type of cancer, are the changes in libido and desire, impaired sexual arousal, so it takes a long time to feel arousal, or it might impact arousal altogether, and orgasmic changes and or lack of orgasm. So knowing that it's 100% of women, I'll just be bold and say 100% of women experience some form of change. And again, that could be changes in body image, it could be changes in mental health, it could be changes in sexual function, but all of that impacts the way we view our sexual body, the way our body sexually is responsive. That why aren't we talking about it? And this is a very old study. I want to point that out. It is very old, but it remains true. And all the conversations and current research still remains true that the reluctance on both the healthcare provider and the patient is often about protecting one another. But the one I like to point out is that very last bullet, that 76% of people feel that treatments don't exist to treat their sexual dysfunction. And so what I hope tonight together we change is that you see there is not only hope, but there is opportunity. And again, it might look different. It may not be the same as it was prior to cancer, but there are lots of opportunities to treat any challenges or changes you face in your sexual self. Some of the physiological alterations that women report are certainly hormone changes. We know that whether it's chemotherapy that might thrust you into a medically induced menopause, maybe you were perimenopausal and it thrust you further in, maybe you're postmenopausal, but it's continued to have impact. Chemotherapy, surgery to remove the cervix, the ovaries, if you've had any kind of treatment that is hormone suppressing, certainly that can impact your hormones. We know that there are significant consequences to ovarian failure. And again, that might be medically induced menopause for those of you who were perimenopausal or premenopausal and chemotherapy or surgery forced you into menopause. That can very quickly alter the integrity of your vagina. So you might notice changes in the vulva, you might notice changes in the vagina. Vaginal stenosis is very common, which is the narrowing of the vaginal canal, and we'll talk about that. There may be changes in blood flow, which impact the lubrication. It impacts the way that it feels, whether it's masturbation or intercourse. You might have experienced infertility, which can influence the way you view yourself as a woman for some. And some of these other that I talk about, osteoporosis, hot flashes, mood changes, weight gains, again, or weight changes, weight loss, or weight gains, those can certainly have an impact on the way we view ourselves, and can influence our behaviors. If we know we're going to have hot flashes all night long, we may be avoidant of being sexually intimate with ourselves or with a partner or partners, because the hot flashes become so uncomfortable, or we don't know how to manage them in a sexually intimate relationship. That vaginal stenosis I talked about is common, again, can be brought on by chemotherapy, certainly if you've had radiation to the pelvis or pelvic area, and menopause can thrust into that. Simple things like fatigue, decreased physical stamina, mouth dryness, all of those influence our ability, willingness, energy to be sexually intimate, whether that again is with ourselves, partner or partners, or even the idea or interest in being sexually intimate with ourselves, partner or partners, can be influenced by these side effects. And then we know that changes in subjective pleasure, so nipple stimulation, clitoral stimulation, maybe if you had head and neck cancer and had radiation to your head and neck, that area that used to be sensitive to being kissed, maybe it has no feeling anymore. That certainly can change the way, again, that we view our sexual bodies, or some of those changes might influence sexual pleasure, sexual patterns that you had with yourself or a partner or partners. And so redefining, recreating, re-navigating. My nipples no longer feel anything, so you can spend as much time there as you want, and they're not doing anything for me. Educating your partner or partners about that is really important. And again, it does change that sexual interaction with yourself or with a partner. And then all the medications we give to treat symptoms or side effects, whether it's managing mood, whether it's managing pain, fatigue, energy, those can further exacerbate sexual changes or challenges. So having a conversation with your physician about the medications you're on to manage side effects or your mood can be really important, because they may actually be creating more challenges for libido or orgasm than maybe you had intended or wanted. So I'm going to just get right in there with the number one complaint of women that I hear the majority of the time, which is low desire. And one of the, what I would call myths, is oftentimes women will come in and say, I have no interest. And I'll say, well, that's interesting, because you're sitting here in my office saying you have no interest, but you have interest in having interest. And they'll say, yes, I would love to have interest. And I say, you have interest, you have desire, it's just low. It's not what you used to think it was. It's not being triggered by being kissed or seeing someone you're attracted to, or in the ways that used to make you feel sexual or sexy. It's not having the same response. But low desire does not mean no desire. If you have even the desire to have desire, you have desire. And I think sometimes we become very fixated on, my body doesn't have the same arousal or doesn't think about being sexually intimate, therefore I don't have desire. Really, desire is your mind. It is about putting thoughts in your mind. It is about thinking sexual thoughts, and that can influence your body's willingness, interest, and availability for a positive sexual experience. One of the things that addresses low desire the best is, in a relationship, is counseling and education. making sure that you and your partner or partners understand what desire is and what it isn't. What it used to be at 22 when we could look and be aroused is no longer as we get older. And that's just the reality of aging, and which cancer further exacerbates, right? It exacerbates the aging process. But it also is the reality of, for many of us that are trying to work jobs and manage kids, spontaneity and desire change as our lives get busier as aging women. So addressing those relationship issues, if there's a disconnect between you and your partner or partner's desire, or you and your partner or partner's expectations around frequency or what that looks like, it's really important, because it's really important to seek out help, because that can really help also dismantle this idea that desire means I'm aroused, or I'm coming on to you, or you'll know I'm interested if I am vaginally wet, because for many women, that vaginal moisture completely changes. So it's no longer an indicator of desire, or it's no longer an indicator of being aroused. So that education piece is important for the partner or partners. Also, when we're thinking about low desire, really important, as I mentioned before, to assess that body to brain expectation. So am I expecting that I'm going to think that I want to be aroused, for example, and then my body's just going to do it? No, we've got to really give ourselves the opportunity and awareness and environment to increase our desire. So that may mean having more time for foreplay. It may mean that desire comes after kissing, because the intention is, I want to feel connected. I want to feel aroused. I'm not there yet, but kissing feels good. It feels nice. It feels natural. And arousal comes after. Again, shifting our expectations around what maybe was to what can be. Certainly, we always want to rule out any kind of medical contributions. As I talked about, that comorbidity of medication sometimes can negatively influence our desire and our libido. If we are anxious, if we're feeling depressed, if we have lots of negative thoughts about our body, we can't think our way out of that. We've got to do the right work to be able to embrace and heal that part of ourselves, so that when we are in a relationship, or even a relationship with ourselves, that our sexual body responds out of kindness and caring to ourselves and our sexual self. And certainly there can be other sexual dysfunctions that may be present. Maybe there was some prior to your diagnosis that are further exacerbated, and or maybe your partner or partners are experiencing something. Cognitive behavioral therapy is one of the strongest and most successful approaches to addressing low desire, because again, our thoughts certainly do influence our feelings and our behaviors. And if my first thought every morning when I get out of the shower is, oh, you look like that again, what does that do to our own sexual esteem, our own body? It sends the message that we are either not sexual, or we're not attractive, or we aren't interested in even ourselves. So really thinking about how we can cognitively restructure our own thinking is important. So something like, I'll never be the same again, which many women have after a cancer diagnosis, to shifting towards, life will be different. I have incredible strength, and I am confident that I can find new ways of satisfaction, right? It's not saying I'm the sexiest person on the earth, or I can have the most amazing orgasms. It's really just changing that cognitive dialogue to, I'm broken. I hear from some women, I'm a pincushion. My body's just meant for, for now it's in the forever stage of healing, to thinking through, what, life is going to be different. My body is different, and I can love and support it and help it heal. Very different conversation with ourselves, which influences the way our body is receptive to intimacy with ourselves or a partner or partners. Also changing that expectation, again, of mind to body, that mind piece. If we can really hone in on erotic focus, so when thinking about if you're in a partnership or not, let's talk about if you are in a partnership but not yet sexually active with that partner, or if you're single. That erotic focus is about really thinking through, what does it feel like? What is the thoughts that are associated with, whether it's being sexy, whether it's being aroused, whether it's being turned on, whether it's being desired, right? What are those thoughts? And how can I bring my focus to, that feels really good. When he or she or they kiss my neck, that feels really good. And bringing that focus into that erotic experience, instead of thinking of the laundry list or the laundry or all the things that don't feel good, really bringing into all the senses, what we smell, what we taste, what we feel, can be really powerful. If we're anxious, if we're worried about there being pain, if we're worried about it not feeling good, relaxation and doing just some of that simple deep breathing that we do for anxiety management can actually have great power in our ability to experience our sexual bodies. And if you're in a partnership, couples therapy is the most effective way to manage some of the challenges that we face sexually in a relationship. And that could be emotional intimacy, that could be sexual intimacy, it could be your own personal sexual body or your partner or partner's sexual body. Other things that we've realized have helped address low desire. There is a prescription, flibanserin or Addyi. It actually was used as an antidepressant originally and has been approved by the FDA as a treatment for low sexual desire in premenopausal women. So it could be something you could discuss with your GYN or your medical oncologist. And for some women, some, not all, hormone replacement therapy is an option and is a good option. And whether that's systemic hormonal or localized hormonal therapy, it is an effective treatment in relieving many of the symptoms of menopause. Also an effective treatment in helping intercourse, whether that's oral or vaginal intercourse, to be more comfortable. But really important to point out that hormone therapy can sometimes improve desire and can sometimes help enhance orgasm. But if there is a negative relationship with your body, or if there is a brokenness in a relationship, a sexually intimate relationship that you have, we can prescribe you all the hormones possible. And it doesn't necessarily mean it's gonna improve desire or orgasm or other sexual dysfunctions, because those things, the relationship with yourself, must be addressed in tandem or first before the others can be. One of the other significant challenges women report, again, regardless of cancer diagnosis, is vaginal dryness and pain. And you can experience vaginal dryness on the vulva, the exterior of the vagina. You might notice that there's dryness there, that the skin feels dry, the labia feels dry. You also most likely are experiencing vaginal dryness inside of the vagina, which causes painful pap smears, or as well as painful intercourse, or if you're using a vibrator or a dildo, can also be very uncomfortable. So first and foremost, if you have discomfort with masturbation, with vaginal intercourse, whether that's with a penis or a toy, seeing your GYN and being assessed is important. And then getting a referral to a pelvic floor therapist or a pelvic pain physician is really important. Pelvic floor therapists are, I call them angels. They are amazing. They're physical therapists trained specifically in they're trained in all things, but they focus on pelvic floor therapy, helping to strengthen the vagina in general, to, again, help with, if you sneeze, not having incontinence, having comfort with exams, as well as comfort with intercourse. In addition to addressing vaginal dryness and pain, I call it the exercise. We tell you when you're going through treatment that exercise is good for you. Keep up your exercises, keep up the muscles, because the more we don't exercise, the more likelihood our muscles are going to atrophy. And the vagina is no different. That is a muscle that needs to be exercised. And so I often say, think of it as kind of tongue-in-cheek vagina gym. It is vaginal strengthening. So you strengthen, stretch, and moisturize. And you strengthen by doing Kegel exercises. You stretch using dilators, which are available often in the radiation department. But as much as I love that we give them out in the radiation department, they're often hard. They're big, they're heavy. So there's a website called vaginismus.com that sells a set of dilators for about $45 that are more malleable, they feel softer, they're lightweight, they're easier to clean and use. And there are others like that, but that's just one reference. So you insert the dilator, which for those who don't know, are similar in length and size to tampons. So the smallest might be the size of my pinky, and the largest most women never have to get to. If you can get to that medium size dilator, whether it's for a gynecological exam, whether it's for a dildo or a vibrator, or whether it's for a penis, that should provide enough stretch and strengthening for the comfort of insertion. In addition to dilator therapy and practicing Kegels, so the squeezing of that pelvic floor, if you think about a Kegel or Kegel, some people use that interchangeably, it is that muscle that we use that when we're trying to hold our urine, when we have to go to the bathroom and we have to hold it, it's that squeezing kind of right in the anus, the floor of the pelvis that we squeeze to hold. That muscle is that muscle that we squeeze around the dilator and then relax. Squeeze and hold and relax. Again, it helps with strengthening that pelvic floor. We squeeze that around the vaginal dilator, which gives us that muscle feedback of I can feel it, I'm squeezing it. Some, you might be able to only hold it for 2 seconds initially because the pelvic floor has become so weak. We want to work up to holding that for 30 seconds, for 45 seconds, but doing that a few times a week is really important. In addition, before you insert the dilator, knowing the difference between moisturizing and lubricating is important. So externally, we use lubrications, or if we're applying it to a penis or a dildo or a dilator for insertion into the vagina, you would use a lubrication. Yes, a lubrication. The difference between a lubrication and a moisturizer is used similar to how we use lotion in our body. It is meant to seal and help protect the skin. Moisturizers, for example, like a Replens, are inserted into the vagina, not meant for lubricating or being inserted with a toy or a penis, but are inserted into the vagina and left to, again, help address that vaginal dryness. And that is a really important tool and something to make note of. Moisturizers should be used on a regular basis. They are not used for intercourse. It doesn't hurt if you use them while having intercourse, but not meant for. They are meant for the moisturizing of the dermis, the skin, that internal part of the vagina, to help with the elasticity and moisture of that. So again, stretch, strengthen, and moisturize. Vibrators can be used, whether inserting into the vagina or for clitoral stimulation. So the stimulation of the clitoris, if you have an intact clitoris, the stimulation can allow for blood flow. And when we think about wounds and healing of wounds, what do we need? We need blood flow. We need that circulation. So bringing blood flow to the clitoris, to the vulva, to the labias, that allows for, again, blood flow, which can be healing, which can be helpful. It also is stimulating. And when stimulated, it also can trigger for the mind, oh, that's arousing, that feels good. And that can lead to more positive sexual outcomes for you. There are certainly prescriptions like Osphena, or as I mentioned, Addyi. Osphena can help with blood flow. It can help with some of the vaginal health concerns that women have. Osphena does not fix libido. Again, libido is in the mind. So if you're not attracted to your partner or partners, if you're feeling low on yourself, that is not something we can prescribe and fix. That's really about working through with a therapist on that. And we also know for women who can do any kind of hormone therapy, that randomized clinical trials do show that DHEA can improve sexual functioning. Again, it doesn't fix up here, but it can improve sexual functioning. In addition, other topical systemic estrogens can help. If you have the ability to assume a different position during intercourse, if you are able to turn on your side, or you're able to be on top, if you're having intercourse that allows you control for penetration or depth of penetration, that is really important, because again, it gives you the sense of being able to insert at your own comfort and being able to insert at the depth in which doesn't create harm for you. Always with increasing any kind of vaginal moisture, the longer you can prolong foreplay, the more your body is able to respond and become more aroused. And with any kind of, if there is vaginal pain, the last thing I would want for any person would be to force something that creates more pain. So sometimes that means non-penetrative sexual activity. That means kissing, means making out. It means finding other ways to mutually masturbate each other. Maybe it means oral intercourse. There are other ways to have non-penetrative sexual activity that can be just as pleasurable and not create pain. There is a treatment that has not been FDA approved, but has shown great success. It's an intravaginal laser treatment. Mona Lisa is one of those trademarks, but it is essentially like a microdermabrasion treatment for the vagina. So it does, it helps rebuild collagen and helps non-hormonally rebuild the elasticity of the vagina. So although it's invasive, it is like a dilator or a dildo inserted in the vagina for just a few minutes. It's turned clockwise, and it does the treatment on the inside of the vagina. Usually it takes about 3 treatments and then an annual follow-up for maintenance. But women, especially those who can't do hormone treatment, those with metastatic disease, have shown and reported great success with this treatment. And there is also the ARO-C, which is a prescription-only treatment that is similar to a penis pump for penises, but is specifically developed to attach to the clitoris. It looks like a mouse, for the computer, with a suction cup on the end. And that suction cup attaches to the clitoris and helps draw blood flow down to the clitoris to help both with healing, but also improving arousal and response, and has in clinical trials also shown great success for improving and addressing vaginal dryness and discomfort. Hot flashes. I know from so many women that they talk about how it creates so many barriers, not just for intimacy, but activities with their friends. One woman I know that was having like 32 hot flashes a day, was just miserable. She's constantly, taking off, putting on, fan off. And it was really influencing her ability even to sleep comfortably with her partner. And so addressing hot flashes, whether that's, again, through non-invasive ways, like some of the non-hormonal ways we can treat hot flashes like black cohosh, or a little bit more like acupuncture, can also be a way to address that. And then having conversations with your partner about what's comfortable, what's not. That, yes, I might get aroused and I might get very hot, and we might need to pause for a minute, but we can get back as I cool down. All of those are important to manage. If you haven't heard of the Chillo is like a gel pack that you insert into your pillow that keeps your pillow nice and cool, so that your core, your head stays cool and the rest of your body can stay cool. That's a great option for addressing hot flashes. Hormone therapy can also help, but again, it's not for every woman. And I just bring this up as a conversation, not to diagnose or to direct you on what you should take, but to say, have a conversation with your physician about what your options are if hormone therapy is an option. And even for those who are ER/PR positive, sometimes there are local treatments that a physician might be willing to do if your quality of life is greatly impacted. And that's really about having a conversation with a trusted provider. Other non-hormonal ways to treat hot flashes There are some antidepressants that can help, Effexor, and some others. You can talk to them about is a vitamin E option. Are there any dietary changes I can make? Certainly decreasing or restricting alcohol can make a significant difference. Exercise and keeping that healthy balance can also be very helpful. One of the other areas that many women bring up is, I don't know what my body's going to do, Sage. I feel completely disconnected from my body. I want to be intimate with my partner or myself, but I am scared. Last time I tried, it hurt. Or last time I tried, I didn't really feel anything, or I wasn't really into it. And that made me feel bad. It made my partner feel bad. So some of the things when we think about how do we talk about our worries about performance, will our libido be different? Will our orgasm be different? Will we feel differently? Will our partner or partners notice that we're different? First, I would say, let's just start with getting fully self-focused. Don't even put the pressure of being with someone else. Let's get into just staying very self-focused. Get back into your body. What feels good? What doesn't feel good? What have you not touched in a while that maybe needs to be touched? Have you explored your whole body, including your collarbone, your arms, your legs, your thighs, your feet? So much of our mind gets on these two areas don't feel good anymore, therefore everything's off limits. But if we really think about it, if you were to take a green crayon and a red crayon, and with a stick figure, color the areas of your body that still feel nice to be touched, and forget arousal or turned on. Just think about what feels nice to be touched, what doesn't hurt to be touched, what feels good. The majority of us would color a lot of green, and then the red is for the areas that really don't have any sensation or may hurt when they're touched. Oftentimes, again, those are small, they're small areas on our body. And so if the skin is the largest sex organ and the mind is the most powerful, think of all the possibilities that you have to still be sexually intimate, to still feel sexually aroused or close to yourself or to a partner. So staying self-focused is really important, because getting to know your own body, getting to know the changes that you've experienced will allow and empower you to navigate the relationship with a partner or partners, should you choose to. Thinking about, as you stay focused, what feels good. Thinking about even setting the scene. What music allows me to feel calm? Can I have a glass of wine? Can I light a candle? Can I set the stage? Can I draw a bath? Really getting yourself back into just your own internal connection with yourself, so important. And then are there things that you can wear that make you feel sexier, or maybe masculine is what you feel more attracted or you feel more sexual in? Can you do things, wear things that allow you to connect with that more sexual part of your body, your sense of self? Also getting back to what feels good in your body sexually. So whether it's, if culturally and religiously appropriate, masturbating to find out, again, what feels good, what doesn't feel good, touching your own body to connect with what feels good, prolonging foreplay if you're in a relationship, really extending, as I said earlier, extending that time that you're enjoying each other's bodies. And again, getting back to some of those relaxation techniques. So sensate focus exercises, if you're in a partnership, are actually meant to remove penetration or the arousal of sex organs in the first few weeks. It's just really getting into touch and sensation and being able to verbally communicate what feels good, what feels nice, what's arousing, what doesn't do much for you. And it's on both parties' parts. So it's you and getting to know your body, and your partner or partners getting to know your body. And then it's you doing it to your partner or partners as well. So it's shared experiences of what feels good. There's a book written by Sally Foley, Sally Cope, and Dennis Segru called Sex Matters for Women. And there's a great chapter in there on sensate focus exercises and really getting back into your body. So again, it's a way to provide physical closeness if you're in a relationship without the pressure of performance there at all. It uses touch and massage to stimulate closeness. So you might start one morning, afternoon, or evening with a more firm massage and see how that feels. And then you might try more of a gentle, soft, just brushing of the skin and see how that feels. You might want to try different temperatures, ice, warmth, to see how that feels. And again, the whole and sole purpose is getting back into your body, getting back into what it feels like to be touched, to have sensual touch, not sexual stimulation, but sensual touch, and refocused on that area. So why, if we're in a relationship or we're thinking about dating, why aren't we talking about these changes that we're having in our bodies as women post-cancer or during cancer? Obviously, there's internal challenges. We might feel like there's concerns about how do we begin to reestablish intimacy when we haven't been sexually intimate or physically intimate throughout my entire cancer treatment. And now I don't know how to even begin. I don't know how to begin the conversation with my partner or partners. That is one of the barriers, is just how do we start even just, again, that beginning, the kissing, the holding hands when my partner's been my caregiver, or I've felt so sick and I just haven't been really at all interested in connecting in that way. It's starting with some of the basics. It literally is setting time to do a date, to hold hands, being intentional about the time, laying on your partner or partner's lap. Some of the basics, getting back to those basics that maybe when you were dating, you did more of. There's often challenges in communicating. How do we ask for what we want? And sometimes verbally asking for what we want can be a real barrier for people. So I want to free you up and think there are lots of ways to communicate to our partner or partners what feels good, what doesn't, and what we need. Certainly, if we can communicate it verbally by saying something like, ever since my cancer diagnosis, you're not touching me as much. It makes me sad that cancer has changed this aspect of our life. I would really like it if we just incorporated touch back into our relationship more, right? That's a real clear communication. It'd be great if we can be that direct. Or when you're kissing me on my neck, it really doesn't have any sensation, but I love when you kiss my mouth, or my nipples aren't stimulated anymore. If that's arousing to you, that is fine. Just know it's not arousing to me, but here are the things that are arousing to me. Being able to communicate, obviously, with our words has a greater impact often, but there are other ways to communicate what does and doesn't feel good. If we think about if we're sexually intimate, we can make sounds that indicate something feels good, and then we can stop making a sound if it's kind of whatever. We can move our partner or partner's hands or mouth or other areas of the body to the places that feel good, or move them away from the places they don't. So again, when there's a challenge of communication, if you can't verbally communicate yet, one, I would say maybe that's a great opportunity to seek out support and counseling, but also there are other ways to communicate, including you could write it down in a letter and share it. Oftentimes, if we're not talking about it, silence may be interpreted as a lack of interest when really we're just not comfortable talking about it. There's also often from women, whether they're in treatment or they're post-treatment or they have metastatic disease, there's a fear of rejection, of initiating and being rejected. And I will tell you that fear is just as strong in your partner or partner's mind as well. They don't want to initiate and be rejected, or initiate and feel like they're being selfish, or initiate and have fear that they're going to cause harm. So it's on both sides. And certainly if there were previous issues in your relationship, that can cause challenges as well. Maybe you experienced after your diagnosis kind of a honeymoon phase and things were great. And then as things settled in, or after you've completed treatment, things have gone back to the way they were. That can certainly complicate matters. And as I said, I will often, I'm going to be very heteronormative right now, but this happens often. I will get a woman who walks in and is pulling her, what I would say, unsuspecting male partner into my office, who knows I'm a sex therapist. They sit down and she shared nothing with him on other than they're coming to see someone. And in that moment, he is looking like a deer with headlights because he knows something's coming. And in the first 5 minutes of, how can I help you today? She unloads. And by unloads, I will give you an example. I know you don't find me attractive anymore. You never touch me. And I am so angry that cancer changed this aspect of our life and that you can't get over that I don't have a breast. Often, 99.9% of the time, the male partner is sitting there, usually gets tears in his eyes and is really dumbfounded because his experience is, I was trying to give you time to heal. I didn't want to come on to you too strong. Last time I tried to touch you, you hit my hand away. When I touched you last time, you said it hurt. I don't want to cause you hurt. And there hadn't been a conversation to allow for them to connect over what each of them wanted. And so the breakdown really wasn't he wasn't attracted to her, or that he didn't want to be sexually intimate, or that he cared at all that she didn't have a breast. It was he didn't want to cause harm. The same goes for recently, a lesbian couple I was treating came in. She said, you never touch me in the same way that you used to touch me. You don't seem interested in wanting to be sexually intimate. You're not even trying to be sexually intimate. And her partner, again, tearful, said, when I tried, you don't respond. You don't get wet. You don't seem to enjoy it. And what that right there in that 1 minute allowed us to have a conversation on was the expectations and differences in her body that had changed. She's not going to get vaginally wet. She's not going to have the same indicators of arousal as before. So she's going to have to trust her partner when she says that feels good. She's going to have to trust her partner that when she is eager and interested, that even if she isn't giving the previous cues of arousal or previous cues of enjoyment, that she is enjoying it. So again, communication and education can be very powerful, and talking about what you want, what you need, can also be really important in getting what you want and what you need from your partner or partners. So I gave a little bit of an example of this before, but how do we specifically ask for our needs? And we could flip this to being non-sexual and being about intimacy with our friends in the same way. Stating a fact, a belief, a feeling, and then a need for action. Stereotypically, as women, we typically are really good at stating a fact, a belief, and a feeling. You know, ever since my cancer diagnosis, you touch me less and we haven't had sex. Fact. I think it's because my scars are a problem for you. Belief. When we don't have sex or don't touch, I feel lonely and I miss being close to you. Sometimes I also feel angry that cancer affects our sex life too. Feeling. Oftentimes that's where we leave it, and we don't give our partners any opportunities to create change. They don't know what that means. So we've given them this bombshell, and then we don't give them the tools or state what we want them to do differently. So that next step is really important. I would feel much better if we had sex more often, and if it was your idea more often, or if we had sex once a week, we can make it Thursday nights. Giving them the opportunity to respond is so important. Now, the key is when we open that door and we give them a fact, we give them a belief, we give them the feeling, and we give them the action, what we state our needs are, we do not have the opportunity, or we cannot take advantage of, when they give us what we need, to then say, you're just doing that because I asked you. What we have to do is say, thank you for listening. Thank you for responding. And thank you for hearing what I needed. So again, important, you can flip this in an intimate relationship. Ever since my cancer diagnosis, you don't ask me about anything outside of my cancer. I miss us talking about life. I think it might be because you think that your problems are less important. But when we don't talk about life outside of cancer, I feel really lonely and isolated. I would really like it if you talked more to me about what's going on in your life, what's happening with your kids, what's happening at work, because that makes me feel connected to you, right? So same thing in an intimacy statement. So if you are single or you're in multiple relationships and you're dating, fear of rejection, of putting yourself out there, can be a very real fear. So the questions of when do I tell someone I'm romantically interested and I've had or I have cancer? What if I'm in a relationship or I'm dating and the person isn't interested? What if I don't have a partner and I'm still interested in being connected to a partner? A few things to keep in mind. So first, I will often get asked the question, when do I tell someone that I have or I've had cancer? And I do not have an answer for that. My answer is typically, how do you typically disclose things in your life? Like if you have a crazy mom, is that something you share on your first date? Or do you wait until you're kind of really interested in this person, you know this person's interested in you? Everybody is different. If you're the kind of person that has posted all over your social media that you have cancer, then you better be prepared to talk about on your first date because you know they've searched you up and it's all over there. Once you put it out on social, private or public, don't expect that private is actually private. So if you've put it out there, know that they've probably searched you up and they know that you have cancer. So be willing to have that conversation on your first date. If you haven't, and you've been more private, you have space and time to decide when is. Oftentimes what I'll say is, you are so much more than your cancer. There's so much more to you. Even if you're in the midst of cancer treatment right now, this is a snapshot in time. You've had years before cancer and you'll have years after. What makes you who you are? Let them get to know that part of you. And then you can talk about the cancer diagnosis and certainly do it before you start having really strong feelings. And if they choose to not continue dating you because of your cancer history or your current treatment, that doesn't make them a bad person. It gives you the clear pathway that they aren't the right person for you. It also indicates that when hard stuff comes up, they're probably not the person that you're going to want in your corner. So it's not that they're bad, just they're not right. If you're in a current relationship and your partner isn't interested in being sexually intimate for whatever reason, maybe they're struggling with their own depression or anxiety, maybe there just hasn't been time. Remember, again, being very self-focused is important. And if self-pleasure and masturbation is not aligned with your cultural or religious beliefs, I would encourage you to talk to your faith leader about what some options are for feeling sexually connected and intimate. Remember, oftentimes, if your partner isn't interested, 99.9% of the time, it has nothing to do with you. It has to do with something that they're struggling with or going through. And again, communicating about your needs can be really important. From what we just talked about, that's a suggestion that the National Cancer Institute puts forward. Fact, feeling, belief, or fact, belief, feeling, and action is really important. And surrounding yourself with people who fill you up, whether you're in a partnership or you're not, having people that bring you joy, people who build you up, people who remind you at the core of who you are, so important during the cancer journey and after. For those of you who have advanced disease, I always feel it's important because there are many women who have early stage and are in curative stage, and there are many women who are living in 3-month segments or living with advanced disease. So there's certainly, I want to acknowledge, there is the heightened recognition of loss. The loss of sexual function is just another loss that might be experienced. And it is different for those of you living with advanced disease than for those of you who have curative cancer. And you might need to redefine sexuality and intimacy as your treatment course changes, or if you're on a chemotherapy that just makes you feel crappy, you might need to think about what are the days that you don't feel crappy and plan for that, because oftentimes those are predictable. Plan for that to be the time that you and your partner or partners plan for intimacy. Even if that's once every 3 weeks, it's a planned shared experience. Maybe if you're not in a partnership, it's the planned intimacy with your friends and family that you set time aside for. And the need for intimacy often with advanced disease is greater than the need for sexual activity, but that doesn't mean that sexual activity isn't important. Additionally, one of the things I'll work if you're in a coupleship or if your family is a caregiver is really identify the times that are patient caregiver time. So if they're helping bathe you as a caregiver, can that also be flipped upside down and be intimacy time? So turn it into time where you feel vulnerable, where you share your feelings about the day, where maybe it is a little bit more sensual. And then what is caregiving time if they're getting your meals prepared, and separate them out. Maybe partner time is laying on the couch, watching a movie together, and just enjoying time. What can you do on your own, and define that? What do you want assistance with? Do you want this to be by your partner or maybe someone else? Maybe you'd rather have your mom, your dad, your sister, your brother, I don't know, someone else help you with some of the things that you might need. Maybe you need help showering. Maybe you don't want that to be your partner. And can you adapt your time together to the current limitations? So again, if you don't have the energy to do the nightly walks that you used to do you have the energy to sit up in bed and talk for 10 minutes, or watch a TV show and respond to it together? Talking about some of the worries you have if you have a fear of pain or the side effects, managing those together. That I know on Tuesdays, 2 days after treatment, I'm going to feel better. Can we make sure we have a date that night? Or I know I'm clearest and chemo brain isn't bothering me as much during the hours of 12 and 3. So can we schedule a lunch bunch a week where we can just talk? Managing and learning how your body is adapting to the treatments, and then being flexible with how you fit in intimacy is going to be important, because it puts control back in your hands too. We know, again, that oftentimes with advanced disease, healthcare providers are more dismissive. They're not asking you about, how's your sexual intimacy? How's your sex life? How are you feeling physically about your body? And you're not provided with a lot of information. So unfortunately, initially, you might have to be the advocate. But once they hear you ask the question, they're going to be responsive. So I'd love to wrap up with a couple of thoughts related to body image. This plea that I hear often from women especially, dear body, please heal. I don't know how much of this I can take. I know I need to be patient, but please love me. This thought of, again, some of the most common body image challenges are physical and behavioral, right? We know that weight loss, especially in our society, in the US society, that beauty is so external, right? Tall, skinny, blonde. Even with our more body positive culture, there's still so much layering on what is sexy. And femininity, or if we identify more with masculinity, can be challenged by the changes in our body, the disfigurements that we have. Maybe they're not visible, but they're invisible, and we feel even more vulnerable because they're not as visible. Maybe they're more visible and we feel vulnerable because of that. All of that can certainly be correlated with dysfunctional thoughts or maladaptive behaviors. Maybe we hide more, we withdraw more, and our negative emotions. So if we notice that we're avoiding social situations because we don't want to show up because our hair isn't the same, or we don't want to wear a wig, or we're worried about the scars that our treatment has caused, if we notice that we're constantly feeling a sense of anxiety, depression due to some of the anxiety we have around body image challenges or changes, that's when you should know it's time for me to talk to a professional. So as we think about building self and sexual esteem, before we get into our Q&A, finding 3 things that you like about yourself. So getting in front of the mirror and looking in the mirror and picking 3 things that you like about yourself. Fully dressed. Maybe it's your eyes, the way they light up when you smile. Maybe it's your smile. Maybe it's that, your physical body looks strong and healthy. Anything that you can think of, you go from picking 3 things that you're fully dressed to being in something that you might present like lingerie, or if it's boxers and a t-shirt, whatever makes you feel more sexy, to being naked. Going through that exercising and finding 3 things you find sexual, attractive, or you like about yourself is really important in each of those scenarios. Practicing affirmations, what we put in our mind is so powerful. If I put in my mind, again, as I gave the example before, oh, I look like that, and that's something I say to myself every day after I get a shower, my reaction is going to be depression, it's going to be anxiety, it's going to be nervousness about hanging out with people. But if I can say something positive, I can put sticky notes on my mirror, if I can have my friend text me something positive to put in my head every morning, I'm going to have better outcomes. And then supporting and adapting those new limitations and abilities. That might mean, like, I know 3 days after treatment, I feel like just poop. But the 4th day, I have more energy and I'm going to be flexible and gracious with myself. I know that that may change if I change new treatments. Communicating both with our support team and with our care team that these changes may ebb and flow. So what's normal for me today, I may have great energy today. I'm going to totally capitalize on that, where tomorrow I might not feel as great. If we keep going with the expectation that today I felt great, so therefore tomorrow I'm going to feel great, we might constantly be disappointed. So if we can continue to educate our support team that today I feel great, let's take advantage of today. Tomorrow I may not feel the way, we can get the support we need. Taking time to get to know your body, as I said before, get to know what feels good and what doesn't. Do activities that connect with your body, whether that's yoga, exercise, laughing. Laughing is an incredibly healing thing, whether that's with your friends, watching a movie. Sometimes it's just laughing at ourselves can be healing as well. Surrounding yourself with people that lift you up, are positive, affirming. And then if you're worried about dating or who is and isn't going to show up for me, or will I be able to find a partner, think about your previous successful relationships. The majority of them, unless you were 16 or 17, was not based solely off how you look, right? It's about the connection, the appreciation of the intelligence you bring. Maybe it was the cultural religious values you have, but the majority of them are not going to be based solely off how you look. Give yourself that reality check. Is this message really true? Often I'll say, would you be saying that to your friend? And if not, why are you saying it to yourself? And that doesn't mean it's going to stop the thought, but if you can catch it, challenge it, and even offer like, why am I offering myself this thought? This is not a healthy thought. I wouldn't say this to my best friend. Let me find a different thought. What do I get thinking this thought? Nothing. And it's not so easy as, okay, I'll just stop thinking it. But we can change, we can catch it and change it and offer it a different thought, offer it a different lens. And relationships we know are hard enough. They were hard enough before cancer, they're hard during cancer, they're hard after cancer. Managing relationships, intimate, sexual, platonic, are hard. So communicating that fact, belief, feeling, action is really important. Taking time to communicate and talk about what are those new desires? What are those new feelings? What do you want to do in your friendships? What are the things that bring you joy now that maybe they don't know about? What can they do to bring you joy? Can they text you every day a joke? Can they show up and sit and watch a movie with you? Can they take you out and distract you? Making choices that enhance your desire. So thinking about what helps you feel sexy, whatever that sexy is for you. If there were challenges in your relationship prior to cancer, as I say, like cancer may give you a honeymoon period, but it doesn't make them magically go away. You're either going to need to do the work with a therapist or make different choices in your relationship. And give your family and friends their own permission to grieve. Doesn't mean they have to do it with you, but our partners, our loved ones are allowed their own experiences of cancer impacting them as well. Connecting with a clinical therapist, whether that's an oncology social worker or a licensed clinical social worker, about some of the challenges related to sexual health. If you have ongoing sexual function challenges, connecting with someone through the association, the American Association of Sex Educators, Counselors, and Therapists, AASECT.org. You can find a certified sex therapist there to help you work through some of these challenges, and educating your friends, your family, you about the ongoing changes that you might have is really important. Most importantly, maintaining joy. Maintain joy in your life. It's okay to grieve and redefine what your world might look like every day. It may be different for the first 6 months post-treatment. It might be different 3 years when you celebrate a cancer anniversary. It might be different if you're living with advanced disease. We've all heard that cliche of we all live with uncertainty and nothing is guaranteed, but that is truth here. And you can choose to live into that of what do I want to choose today that will bring me joy? Maybe that's sitting, letting the sun hit your face. But it is in some ways, again, if we want to flip cancer up on the upside, it's an opportunity to seek change and seek things that will fill you up. It's also an opportunity to take stock and get rid of the things that are toxic, including people in your life. There has never been a greater opportunity for you to pull that cancer card and get rid of the things and people that suck you dry. I love this ending with this quote because this is really, for me, I think a really important thing to reinforce, that successful coping is not about having a positive outlook or striving to have this cheery disposition. In fact, studies show that coping in a way that is familiar to you can have positive results. In essence, people with cancer should be encouraged to develop realistic expectations about their illness so that they can make good decisions and not be pressured to be blindly positive. We don't have to be Pollyanna. We can be optimistic without being blindly positive. We can be optimistic in today, and a person with true hope will experience a wide range of negative and positive emotions, yet through it all, will continue to try to move forward in life. Remember, skin is the largest sex organ. The brain is the most important organ. So your possibilities for change, for enhancing, for improving are limitless. Thank you so much.